tools and functions for these files. Next, we've got local corrections and using adjustment layers. So this was suggested by Andre Group from the US and Zara Group from Italy.
Once we've quickly gone through a few slides. So in terms of the process, output. But that's pretty much it that's going on in the camera. Obviously, there's a small preview generated, which is what you're looking at on the back of the camera when you're doing a preview. And obviously, if you choose to shoot JPEG in the camera, then there's additional processes that make it a finished file that has to be carried out in the camera. But today, we're going to concentrate on talking about SD card's got my files on. Connect to Lightroom. You do an import process, and basically Lightroom save them as a 3FR, so it doesn't do a conversion, but then it's catalogue, it stores what file it is, it works out automatically what lenses for lens corrections, and obviously you have to switch the correction.
Good evening, everybody. Here is Professor Gonzalo Lopez Nava.
card will show, and you can import the files again to your chosen location, either via the Finder-like interface. We'll do this actually when we're live in focus.
Greetings, Manuel Galvão Neto. It's a pleasure to be among you in the one.
All right, let me just go ahead.
So my next presentation.
then read those raw files using that and allow you to make some controlled edits. What that particular spot color I've selected is. You can then adjust the range color or black and white that I'm working with. and effectively it will apply a reverse linear curve to that, and I'll show you that in a while. We've got some negatives to work on. Once you've got that converted, you can then process with the rest of the tools in focus as you would normally do, and then obviously it's all been completed. So this one is pretty much the best way to go. Alternatively, if you click the layouts button, you have a thumbnails only mode automatically set up for you. Now, the reason why I've got to thumbnails as a 3FR, main window back on, I can click on any file, and as you see, there is no large preview. It's not been created yet. I've just got the small, effectively the thumbnail that's created. then got your metadata, which we'll look at in a while, which is basically a lot of information, copyright information, and so on. And then you have how do you want this particular set of files to be renamed? Because obviously at the moment what we've got is the shooting order number, basically, which may be fine, or you might want to rename something my image is going to go. So in this case, I can go back into here, 3.6 webinar, and create a new folder. Obviously, you would create your folder.
Hello, everybody. I hope you hear me now, I guess. Let us see who's already on board. Okay. Hello, Barham, how are you?
Hello, Ayed. Good, my friend.
Nice to see you. And
Nice to see you.
Thanks for accepting our invitation, Barham. It's a pleasure always to have you with us. We will have with us Abid Al-Lahabi. I think he should be already joining. Abid, you should be already, Muhammad, connect everybody with us, please. I see Abid, I should be joining. He's joining now, okay. And then we will have also Imad Al-Jahdali.
Yes, hi.
Hayak.
Yes, Barham, how are you?
Abid, good. How are you, my friend?
Nice to have you tonight. It's a
Absolutely,
pleasure.
it's a pleasure and honor.
Thank you, Provide, for the invitations, and I hope it will be great.
Abid, unmute your, you should be able to unmute your, Elena Imad. Hayak Allah Imad.
Ahlan, hayakum Allah. It's always a pleasure to join you guys.
Thank you.
Thanks for the invitation.
We will have also Guntrad Levez Nafa and Manuel Galfao. They are trying to connect with them, and we'll have also Eduardo De Mora, and he will be joining us in this panel. Dear colleagues and friends from the Saudi Society of Bariatric Surgery, and all attendants from hopefully Saudi Arabia at least, and around the globe. We welcome you to this session, which is the third session on, or the third day on SASMBS meeting. I would like to thank all our speakers, international speaker in particular, who already contributed and accepted the invitation to be part of this. And thank you so much. Thanks, Barham. Thanks, everybody who's here. And we will start with you, Barham. I know you are the world expert in endoscopic gastroplasty. You are the one who started this procedure in Mayo Clinic. And we'll be honored to have you with us today to talk about the current states and in the procedure, and also where are we now in your study? I know the multicentric study of randomized control trial in endoscopic gastroplasty. So go ahead, Barham.
Thank you, Professor Qahtani. Dear colleagues, it's always a pleasure to be with our Saudi colleagues. It's an honor. I'm going to share my screen here. And is the audio and visual working? Could you hear me okay? And could you see my slides? Excellent.
It's perfect, and we see everything.
Perfect. So my name is Barham Abudaya. I'm a professor of medicine and the director of advanced therapeutic endoscopy at Mayo Clinic in Rochester, Minnesota. It's a distinct honor to be with our colleagues in Saudi today, talking about the current updates on endoscopic gastroplasty and give you an update on the trials in this space. These are my disclosures. First of all, when we start to talk about gastroplasty, it's important to highlight the need for a minimally invasive, anatomy-preserving procedures like the gastroplasties. And the need is simple. We have a pandemic proportion levels of obesity and metabolic disease. And right now, less than 1% of patients who qualify for bariatric surgery get that procedure, and medications have not improved that much at all. Less than 1% of patients who qualify for a medication gets or renew the medication. So we have a gap in those who qualify for these interventions, but also there's a gap in those with mild to moderate forms of the disease with a BMI between 30 to 35 or have no desire to have surgery. Now, so the vast majority of the disease burden is going unmet, and we need minimally invasive, appealing interventions for patients that will increase access to therapeutic procedures that could treat the disease of obesity and its metabolic consequences. As such, the spectrum of care should look like something like that. Our colleagues in cardiology filled that many years back with the advent of coronary stenting, and we're hoping that the field of metabolic and bariatric medicine and surgery would fill the spectrum with a whole gamut of interventions that start from lifestyle intervention, include medications, endoscopic procedures, and bariatric surgical interventions. The hope for endoscopic gastroplasty is to be here in the spectrum. We have a bunch of implantable devices that offer temporary weight loss, like the intragastric balloons and the endobarrier sleeves, and that get implanted in the small intestines. However, with the hope of gastroplasty, we're hoping that we are operating in this zone where we're getting efficacy close enough to bariatric surgery, but with preserving the anatomy, so it's appealing for patients, it's well tolerated, effective, and with a mortality that should reach 0%. So the access could enhance for patients. So the hope for gastroplasty is we're operating at the level of efficacy close to bariatric surgery, not the same, but close, with a safety profile similar to the endoscopic and the non-invasive interventions that we have. And with that, we have two main procedures right now that are gaining significant momentum globally. The first one is the endoscopic sleeve gastroplasty, which is performed by the Apollo overstitch device. With the procedure, we start using these continuous U-shaped suturing that start at the level of the incisura, and we imbricate the greater curvature of the stomach in a sequence of about 6 sutures in order to shorten the longitudinal length of the stomach and to tubularize the greater curvature. In a similar technology that uses plications instead of suturing, which is the Post 2.0, we use an incisionless operating platform to introduce synchronized number of plications, each about 7 centimeters in a particular sequence and pattern in order to result in tubularization of the greater curvature of the stomach and reduction in the length of the stomach for weight loss benefits. That's the procedure. This is an MRI of the patients. We do functional MRIs on these patients to better understand the physiology. And you could see that the cartoon is not much different than reality. This is the stomach on functional MRI, and you could see that the greater curvature of the stomach is imbricated. The stomach is foreshortened, and there is healing and adhesion of serosa to keep the durability of this configuration. And this image was obtained at 6 months after the initiation of the procedure. And this is, by the way, is part of the MERIT trial. We're assessing durability in a sub-cohort using MRI because that's the best way to look at the durability from outside of the stomach. And again, it's appealing because it's preserving the function and the anatomy of the organ. You could see here's the stomach in these functional MRI, fully peristalsing. There is no denervation of the stomach. The pressure in the system is not high. So GERD is not a problem with this procedure, and we will show that definitively in the MERIT trial. And that's why it's very well tolerated outpatient procedure that does not burn bridges for downstream interventions, and it's very accepted by the patient. Thus, the hope it will allow us to increase access to effective interventions for patients suffering from the disease of obesity. Now, the literature is pretty mature about endoscopic sleeve gastroplasty, and it continues to expand. We have probably now more than 3,000 cases in the published literature and more than 20,000 cases performed globally. This is one of the meta-analysis that summarize the results from multinational trials, including our colleague, Professor Al-Qahtani. And you could see at the results are reproducible across the globe, and the average total body weight loss at 12 months is about 17%. Now, more importantly, the incidence of serious adverse events is 2%. And these serious adverse events tend to be events that you could manage conservatively, either with antibiotics or with interventional radiology drainage. They do not require major surgical revision, and mortality so far has been reported at 0%. Now, this was corroborated from a very large series from our colleagues in Brazil that included about 1,800 patients, showing a very similar total body weight loss of about 18.2% at 12 months, with actually a lower SAE rate of about 0.8% in that consensus statement. Now, the durability seems to be good as long as you have the patient in a multidisciplinary program that focuses on changing behaviors and lifestyle. And this is published from our colleague Reem Sharaiha from Cornell, that in clinical gastrohepatology that followed these patients in her cohort for 60 months and showing that as long as the patient are in a multidisciplinary program, the weight loss should be durable up to the 60 months period. So what's new in the field of endoscopic sleeve gastroplasty or in the field of endoscopic gastroplasty in general? The first advancement is that evidence is mature, both from real world and randomized controlled trial. This is the one and should be the definitive trial that investigated the efficacy and safety of the endoscopic sleeve gastroplasty in a multi-center randomized fashion, including multiple academic and community centers in the United States. There's 9 centers in the study, divided equally between surgeons and gastroenterologists and between community and academicians. That means that the results that comes out of this trial are expected to be quite reproducible and does not reflect what does this procedure do in experts' hand, because there's many centers in this study that were not expert in this procedure at the time of initiation of this study. All I could report is that a preliminary analysis of the trial that was submitted to IFSO for presentation in Miami, hopefully later this year for the full trial, showed that both the primary safety and efficacy endpoint has been met. So now with the global results, published literature, and now we have a level 1 evidence from a large randomized controlled trial, we could say with confidence that the procedure is effective and safe for patients. This is the study schema of the randomized trial, included 208 patients, randomized in 2 steps to either endoscopic sleeve gastroplasty or lifestyle control. There was 50 hypertensive individuals and 50 type 2 diabetics that were stratified into this trial in order to assess the impact on comorbidities. And then those who got endoscopic sleeve gastroplasty in year 1 were followed for an additional year, so for 2 years durability results. And those who got the lifestyle in year 1 were crossed over in year 2. And the full study will be reported hopefully in IFSO Miami later this year. So stay tuned. The second advancement in the field of endoscopic sleeve gastroplasty is that drugs are getting better. That's the paradigm. Now we're shifting things to a minimally invasive intervention. So part of the future is going to be these combination procedures where you have a procedure like endoscopic sleeve gastroplasty. You combine it with a medication like semaglutide in order to enhance the durability of the response. And there has been a randomized controlled trial that evaluated this concept. It was presented in Digestive Disease Week in 2021 by Dr. Hoff and our colleagues in Brazil. And the trial looks something like this. It randomized 61 patients, or 58 end up getting randomized 1 month after the performance of the endoscopic sleeve gastroplasty to either semaglutide or a placebo. After the 1 month, patients were followed for 11 months, and the outcomes were assessed at the 12 month period from the endoscopic sleeve gastroplasty. And here you could see, interestingly, is the following patterns. You could see that the combination did slightly better than the individual, which is than endoscopic sleeve gastroplasty. But what's interesting is for the combination, the total body weight loss was about 25.2% at 1 year, very similar to what you get from surgical sleeve gastrectomy. And what's also important is that semaglutide did not double the weight loss that was resulted by endoscopic sleeve gastroplasty. It improved it, but it did not double it, because 18.6% of that weight loss was attributed or was achieved with endoscopic sleeve gastroplasty alone. So it's complementary to the procedure, but not a replacement, in my opinion, for the procedure. The third advancement in the field of endoscopic gastroplasty is that the POSE 2.0 procedure is gaining significant momentum. The POSE 2.0 procedure is performed with this incisionless operating platform that utilizes this device called G-Prox in order to introduce about 7 centimeter plication. These are full thickness plication, anchored by these two baskets in order to create an endoscopic sleeve gastroplasty-like changes in the stomach. This is how the synchronized procedure goes. It starts with this transport device, and we start the plication at the level of the incisura. Again, each plication reduces the stomach by about 7 centimeters, and we introduce about 20 plication. Each plication takes about 20 seconds to perform. So the average length of this procedure has been about half an hour or so. It's very easy procedure to teach because it's very reproducible as far as the plication configuration. And you could see when we place the synchronous plication along the greater curvature, what we're doing is we're tubularizing and shortening the greater curvature of the stomach. And this is what results. This is a stomach before the intervention. Count with me from the fundus to the incisura, you have about 5 vertebral bodies. This is after the intervention. You could see that we have tubularized the greater curvature of the stomach. But now if you count with me, the vertebral bodies after, it's only 2.5. So 50% reduction in the length of the stomach and tubularization of the greater curvature. This is the stomach before, and this is the stomach after the POSE 2.0 intervention. And Dr. Lopez Nava will discuss more on the POSE 2.0 in a full lecture. But I will introduce to you, because my topic is to talk about trials, a multi-center prospective trial, 2 in Spain and 1 in the US under an FDA IDE at Mayo Clinic, that was presented in Digestive Disease Week 2021. It included 44 patients. We measured gastric emptying, we measured weight loss outcomes and durability at 1 year and 2 years, both with clinical follow-up and with repeat endoscopy and fluoroscopic assessments as well. This is the cohort. Its BMI at baseline was about 37. This is the mix of comorbidities that we started with. And here's what we got, and this is now going up to 24 months. Again, we're pushing the durability in our assessments to 24 months, and you could see that we achieved at the 1 year about 16% total body weight loss, and most of the weight loss was durable at the 24 months mark, despite this trial being conducted during a period of pandemic or of the COVID pandemic, and we know the effect that happened from COVID. And this is the absolute weight loss that translates from the study. If we look at percent responders getting more than 10%, you could see at 12 months, 86% got more than 10% total body weight loss, and about 61.5% got more than 10% total body weight loss at 24 months as well. This is the impact on comorbidities. Everything in red has improved significantly. So you could see metabolic profile improved, fatty liver parameters significantly improved, and the quality of life and the eating questionnaires improved in the study as well. Let's focus on the impact on fatty liver, because that's important. And now we have another trial that is a prospective trial that will be reporting about the effect of the POSE 2 on fatty liver. But within the study, we did fibroscans at baseline, and then the fibroscans were repeated at 12 and 24 months. And here what we're reporting the results at 6, 12, and 24 months of the fibroscans. So if you look at CAP, which is a measure of fat content of the liver, and you look at those individuals that had S more than 1, that means they had steatosis more than 1 at baseline, you could see that a score less than 250 means resolution of fat from the liver, and most of them have resolved, or all of them has resolved the fat in the liver at 6 months, and the resolution of fat maintained up to 24 months. If you look at those with a increased fibrosis score at baseline with an F more than 1, and you could see that there was a correlate decrease in the fibrosis score that was maintained up to 24 months after the intervention. Happily, which is an excellent result, is there was no SAEs reported in the study. And if we look at the assessment for durability at 24 months with endoscopy and with fluoroscopy, you could see that the configuration is nicely maintained at 24 months. And this is the correlate video. This is at 2 years. You could see that the plication is there. The tubular shape of the stomach is nicely maintained. There's no ulcerations in the stomach. There's no evidence of esophagitis. So that is a very well tolerated intervention. So in conclusions, my colleagues, endoscopic gastroplasty are minimally invasive, effective, scalable, and durable endoscopic bariatric and metabolic therapies that target multiple physiological appetite pathways. They offer a durable therapeutic option to fill the obesity management gap. And with that, I would conclude and entertain any questions. And thank you for your kind attention.
Thank you so much, Burham. Very elegant presentation. We will leave the question to the end. Hopefully, we'll have more, and definitely we'll have a lot of discussion when we have things together. The next presentation will be for Guntrad Lopez-Nava, who's again one of the authorities in endobariatric, and he will be talking about where do you stand in post-to gastroplasty. Guntrad.
Good evening, everybody. I'm very happy and honored to have been invited to Saudi Arabian Society of Metabolic and Bariatric Surgery. And I would like, of course, first of all, to say a special thank you to Dr. Mofti, President of the Society, and to my friend Ayed Al-Katani to have invited me. He's the conference chairman, have invited me to share this talk with all of you. I am Professor Lopez-Nava. I work in Bariatric Endoscopy Unit of Madrid San Chenarro, Spain hospital. And my topic today is going to be, where do we stand on post 2.0 gastroplasty? First of all, I would like to say that bariatric endoscopy, the role of endoscopy in obesity is to try to increase penetrancy of treatments, try to increase those treated patients, because as we know, 90% of them are absolutely untreated. In order to do this, we have to think a little bit the way patients do, not only thinking on effectiveness and safety, which is very important, but also try to think the way patients do, because in that way, we will increase the number of treated patients. So, for example, patients, they think in scarring, hospitalization time, recovery time, and thinking on this, bariatric endoscopy, it's a very, very useful treatment for them. On the other hand, we have endoscopic gastroplasty. There are different ways to do it, but all of them, they have in common that there are changes that we do endoscopically per mouth in order to increase satiety, diminish appetite, create motility changes, and also try to create different hormone responses. In order to introduce how post-procedure works, I would like to share this study, which is talking about durability of serosa to serosa apposition, concluding that serosa to serosa apposition creates fibrotic, dense bridges that make the fall stand in place with a very good durability. And this is the core of post-procedure. Post-procedure, it's a procedure where we do folds in any part of the stomach. These folds, each of them shortens the gastric wall 6.6 centimeters and creates an enfolding of the tissue, creating a position of serosa to serosa, trying to induce these fibrotic breaches. The main goal of this plication is to increase durability of endoscopic treatments. Here you can see how plications can be in place 24 months. Here are pictures of plications inside at 3 years. And this is the way we do it. Primary obesity surgery endoluminal stands for POSE. And this is everything, it is included in the procedure, and I'm going to try to break down and explain any of the parts. In order to perform a POSE procedure, we use, first of all, on the right part of the slide, we use the transport. The transport is like a plastic scope with 6 channels, and inside of it, we can put the G-Prox, which is like a grasper. We can deliver a G-Lix, which is like a corkscrew to take the tissue. We have graspers of 3.3 centimeters of each part of the grasper, so the fold at the end is going to be 6.6. And also we have a baby port where we can put inside a baby scope in order to have light. This is the picture of a transport assisted by a pediatric baby scope. Those are the multiple operating channels. You have a channel for CO2 deliver. You have a steering controls like a scope, and you have 4 ways to steer the transport in 4 ways. Let's see one plication, how it takes. With the G-Lix, we take the tissue, we pass the grasper, we deliver baskets, nitinol baskets at each part of the fold to make this fold remain in place. This is what we do in POSE procedure, applying different patterns and doing it in different layers of the surfaces of the stomach. In the past, we were addressing with this plication just the fundus with the hypothesis of trying to avoid accommodation of the stomach. We published this experience in 147 patients, 38 of initial BMI, 43 mean age, and initial weight of 106 kgs. I'm sorry, my phone is okay. What we published in this 147 patient was a good total body weight loss. More than 10% of weight loss was achieved in 73% of the patients. 15% of weight loss was achieved in almost the half of the cohort, and more than 20% was achieved in 25% of them, which were enough and good results in terms of weight loss. Where are we now? We have evolved to what we call POSE 2.0, which is the topic of today. What is POSE 2.0? The goal to evolve the pattern in this procedure was to try to narrow and shorten the stomach, to reduce gastric accommodation, not only in the fundus, but also in the main gastric body, affecting gastric emptying, achieving early satiety, and try to reduce, of course, meal volume intake by the patient. Here we can see a little bit how, in this diagram, how we plan to do this. We started with a distal rows of plication, then another medium row of plication, a proximal one, the third row, and then filling the gaps with plications like suspenders, like here. The aim is to narrow and to shorten the stomach. And this is more or less how we did the pattern in the first cases and the study that I'm going to connect slides later. So, as you can see here, this is incisura angularis on the right part of the slide. We have a first route in the right of plications, 4 plications in anterior-posterior sense, another second row of plications. Then we have a third row, and then we fill the gaps in the middle with other plication. Most of the cases, to do this, we took 18 plications, so which is the main the mean number of plications you need to do this approach. This is, for example, the endoscopic view of the first plication, endoscopic view of the whole stomach done the post-2 procedure, another endoscopic view doing the last, one of the last plication, maybe the number 16 or 17 plication in the stomach, another view, and here on the left we can see the X-ray of a new stomach with only 3 vertebral bodies, shorter and narrower stomach, which is the aim of the procedure. Here is an endoscopic view, how it was the stomach before and how it was after. And in this slide, I want to try to break down and explain the suture pattern. So here we see on the right side, we see 2 first rows of plications. Here you can orientate them in the longitudinal axis or in the anterior posterior axis to try to create this image in the first 2 rows. Then we do the third one. You can see it here in every left part of the pictures, endoscopic view, and another diagram view with taking 3, 4, 5 plication. Most of times it can be 4 or 5 plication to do the third row. At that moment, we can see that there is a big gap between the first 2 ones and the third one. So there is a gap in the middle, which is what we call the 4th row, and which is at the end doing like a zigzag to try to fill the gap between the other rows. This 4th row, we try to do it in the anterior-posterior way in order to narrow this diameter. This is a sequence of the steps: tissue acquisition, anchor deployment, plication creation, and I'm going to show you like here. So we start, this is the setup. We need 2 operators to do it. You take the transport of the post, you put the helix inside the tissue at the selected part. Here you can see in the endoscopic view, we are in the middle of the greater curve at the level of the incisura, which you can find it on the right. And we are going to take the first plication. So you direct the helix, you pull the helix, and then with the jaws of the grasper, you orient them in the anterior-posterior direction. You deliver the needle. You can see here in the endoscopic picture the tip of the needle. Once the needle is advanced and you can see the tip, you deliver the thread. You can see it from the tip of the needle. You deliver the thread with a small basket. The first basket at the tip is going to be one of the first, one of the 2 baskets that they are going to put in place, maintain in place the fold. We retract the needle. Here you can see in the endoscopic view already one of the baskets. We retract the needle. We don't see the needle anymore in the endoscopic view. Then we remove the helix. Then we remove the grasper and open the jaws. And we release the second basket. Here in this endoscopic picture, you can see how the 2 baskets are more or less 6 centimeters apart from each other, but there is no fold yet. Now we need to cinch it. We advance this green button that you see on my hands. You advance this green button and you cinch the basket together, creating the first fold. Then you create a suture slack and you cut the suture thread using this blue button and the green one, a combination of the 2 buttons. And this is the way you start to orient the jaws until you get this final stomach appearance that I have shown you before. Endoscopic view, 18 plications are in that case, and this is the X-ray image This nitinol basket sometimes can be seen in X-rays, and which is useful to check and to monitor the patient. This is one fold, one row at 1 year, and that's all. So where are we now in post-2? After we decided this was an evolving procedure from post, and Dr. Abudayev was involved absolutely, Dr. Galvao, myself, Dr. Turro in Barcelona, and we decided to do a multi-center study, trying to be very accurate in terms of doing the same follow-up for the patient. We did first cases in Madrid, San Chinarro in the hospital, and we decided to do this multi-center study, which will be commented by Dr. Abudayev later, more in detail. But we enrolled 44 patients in the protocol, 2 centers in Spain, Mayo Clinic Rochester, and then it was an FDA IDE study. We apply the same intensity of lifestyle intervention and follow-up. We measure gastric emptying, impact on satiety, satiation. Also, we perform control attenuation parameters with elastography to try to measure evolution of hepatic steatosis. Also, we did questionnaires of impact of weight on quality of life, and we shoot for measure durability of the applications at 1 year and 2 years in time. The weight loss that we have achieved in this multi-center study, we can see that, for example, more than 5%, which is what is achieved by medication at 2 years, is still 77% of the patients. More than 10%, which is a very good result for an endoscopic procedure, it's more than 50% of the patients at 3, 6, 12, 18, and 24 months. 61% of the patients had greater than 10% total body weight loss at 2 years, 61%. And for example, more than 50% was achieved in 27% of the patients at 24 years. We have to take into account that these weight loss outcomes that I have commented have been a little bit interfering COVID-19 pandemic, where patients started to do telephone follow-up, and okay, they were at home, and most of them stopped losing weight a little bit during COVID-19. But anyway, we are happy at 24 months with the results of the patient. But the best thing to say is safety of POST 2.0. In the 3 centers, we didn't see any serious adverse event. This is an endoscopic procedure. It is safe, quite effective, and this is what we like it. In Madrid, just in commercial experience in our Madrid center, we have also done another 79 patients, achieving also results at 12 months and more than 20 months. Total body weight loss and percentage of total body weight loss is still at 2 years or 20 months, sorry, between 15 and 20%, which is good. And again, with no serious adverse event. We had one endoscope and one perforation that we solved endoscopically using one of the applications. So we were happy to do this. So what is the impact of POST 2.0? The impact is reduction in hunger in a subjective scale of 50% reduction, what patients say, in volume of food intake, which is very, very friendly for patients that they are trying or struggling to follow a diet. So if you have a reduction of hunger and 50% reduction in volume, it's a very, very good ally to accomplish the diet. So in conclusion, we can say that POST 2.0 is safe and effective. is an option of endoscopic gastroplasty to treat obesity that shows durable changes, talking for an endoscopic procedure. At least we are still watching a 3-year data, but the applications we have seen so far, they are there. Weight loss results meet the ASGE's and ASMBS recommendation, and POSE 2.0 induces weight loss, altering gastric motility and inducing early satiety. Future and limitations of the technique, we are aware that we have to wait and see durability and long-term weight loss. Reproducibility in more centers is needed. Impact in motility with coadjuvant medication has to be studied. And we have to wait for more patients to monitor safety. Thank you very much.
Thank you so much, really, Gontrat, for this nice presentation. And we will move forward to, we'll leave the question at the end. I know there are many questions in the, we'll move the question to the end. We know there are questions in the Q&A, and there is also, I put some instruction on the chat for attendees also. You can raise your hand and I will see it. And also you can put your written questions on the question and answer section. And we'll try to answer all these questions that you raise, some of them on simultaneously while we are presenting, and some of them will be on the discussion. The presentation now is for Dr. Manuel Galfao Neto, who is one of the world authorities in the field of endobariatric, whether he's a surgeon as a background, but he's also doing a very good number of techniques, and whether primary or revisional or treatment of complications. And he's really leading and training many people around the globe. So we will present Galfao.
Greetings, Manuel Galvão Neto. It's a pleasure to be among you in this Saudi Arabia Society of Metabolic and Bariatric Surgery Annual Congress. And I'll thank you very much for the invitation, especially from our friend Ayed Al-Katani. And I will be presenting first about duodenomucosal resurfacing, that I think you already have it. Those are my disclosures. I work with quite some companies on that, specifically one of that developed the first duodenomucosal resurfacing. So I'll offer you to judge if it's going to be commercial or not. So getting to this, just a brief understanding of the size of the problem that we face with the worldwide diabetic spread as an epidemic, as we can see here, and what we can offer in terms of endoscopic interventions. We have those what we call bariatric endoscopy or endobariatric primary interventions on the stomach, space occupying devices. We can alter the anatomy of the stomach by means of suture application. And then we have what we call the metabolic endoscopy, that's the interventions on the bowel. And you will see we were talking about the duodenomucosal resurfacing based on that the mucosa of type 2 diabetic subjects, they are different. So they are altered, they're hypertrophic, and the idea is that if you alter or remodel this mucosa, we can have a positive impact in the course of the diabetes. So with that, we went through all the process to get to the first in human, as you see here, the first publication on video GIE of this process, that we also developed the improvements on the technique to get to the point that we are right now. So the technique is basically you perform an endoscopy, you localize the papilla, and you tattoo or put a clip on the other side. Then you progress in this direction of the trites angle. Then you guide wire, and you slide through this guide wire a very sophisticated balloon that we will distend, we'll touch the mucosa in 3 points. So we will inject methylene blue saline solution, and is lift the mucosa 360 degrees. So we do 3 lifts, and then we ablate this mucosa with circulating hot water at 87.5 degrees for 10 seconds. So the idea is that 2 lifts, 1 ablation, move forward, 2 lifts, 1 ablation. Our target is around 10 centimeters. After that, the balloon is withdrawn, inspection is done, and the patient can go home and stay with a two weeks liquid diet, then return to his normal diet and medications, and we'll follow the course. Just you to have an idea, this is how we do the procedure, endoscopic with X-ray. This is the balloon inside. We don't see the balloon inflated because we need to aspirate the mucosa over that to get a good ablation. But most important is you to see the immediate result, that we can see a clear damage and ablation on the lifted mucosa. And what happens after is that if we just really ablate the mucosa, you have a full recovery, as you can see here in this 1-year follow-up. So there is trials done in Latin America that we start, and then Europe, now in US. And then the first results were published. This one was published in Diabetes Care. You can see here a good impact on A1C from 24 to 12, 24 weeks to 12 months. So it's a very good one. You can see here on the upper right quadrant that we don't have impact on the weight. So it's a metabolic procedure, but we can have a very good impact on the liver in terms of hepatic enzymes of these patients, as you can see here, the inferior right quadrant on that. And on inferior left quadrant, we say the impact on insulin resistance that we have with the HOMA-IR. Highlighting the positive impact on the liver, fatty liver, NASH, NAFLD, you see here that more dark is less fat. So this is an hepatic fat fraction MRI, and you can see here the dramatic improvement from the left to the right in one of those patients. Then, as the studies progress, we have the publication on the gut, that is prospective randomized sham control trial in between Europe and Brazil, and we had statistically significant impact on the patients treated with DMR. They are in light green against the shams or the shams control that they are in gray. So we can see here the positive impact also in the liver on that. So as these studies progress, we have this very specific one I wanted to highlight that was very recently published in GIE, is that the use of the duodenomucosal resurfacing in patients that are already on insulin, with the idea to take them out of insulin. And there's a single arm, 16 patients, and we did they were done the DMR, and then after 2 weeks start the GLP-1 analog, the liraglutide, and then follow those patients in a way that you can see right now. So there was 25 patient screening, 16 was intervened, and a 16 follow-up on primary endpoints on that, using the GLP-1 analog and taking out the insulin. As you can see here, those patients were re-evaluated every 4 to 12 weeks, and if they didn't get better, insulin was returned to that, and the GLP-1 analog was withdrawn. So this is the characteristics, as you can see here, the age, the BMI, H1C, and highlighting that the mean number of daily units of insulin, 31. So what happens in terms of results? At 6 months, we have 75% of those patients out of insulin, and at 12 months, 56% of the patients out of insulin. I also wanted to highlight the fact that the previous trials on trying just with GLP-1 analog to take patients out of insulin, the rate is around 10%. So that's a very positive result indeed. And Not even that. The patients that we could control with DMR and GLP-1 analog have a much better in improved insulin glycemic parameters, as they can see here, in H1C, HOMA-IR, and fasting glucose 6 months and 12 months, and without the insulin. Also, in these studies, the liver was evaluated, and against more dark, less fat. You can see here on the area under the curve, the positive impact of the therapy on those patients. And the metabolic parameters also in BMI and liver, and complete population study, as you can see here. And it adds to the DMR the weight loss, so it's a very positive for that. And this was the base study used, and very recently, the duodenal mucosal resophages, as you can see here, it was approved in a breakthrough approved FDA to designation on type 2 diabetes in patients or adults with insulin-treated type 2 diabetes. So it's a very good news for the field. Also, there is a big US trial to the FDA that it was supposed to start in 2019, but due to the pandemic, it didn't start already, just few centers, and we think that it's going to speed up this year. So this is the INSPIRE study that is being done in US right now. You see a very complex prospective randomized sham control trial. So that's what is covered in terms of evidence that we have, and very recently those randomized trials and meta-analysis. But not like that. It seems that the duodenum is raising lots of interest. So there is another ways to try to do resurfacing. So this one, the laser one, is a company from Israel that they are exploring the possibility of ablate the duodenum with laser. They just show us very briefly a small study of six patients, 6-month follow-up, a 1% drop of weight A1C. They complete the procedure without complications, 78 minutes on average, in minor adverse events. That's what we know up to now. And this one, they already started the human studies in Australia. That's called electroporation or electropermeabilization. That is a technique where we apply electric field on the cells in order to increase the permeability of the cell membrane. So allowing chemicals, drugs, or DNA to introduce in the cell, or just to ablate it. So you can see here how it used. It's supposedly is a very simple procedure. The catheter is thin, it's easier to introduce, so they start the study. And this is some animal data that you can see here, the untreated on the left and the treated on the right. You can see the impact on the mucosa. So we have to see how it goes, but it seems that it's a very promising procedure. Just get a breakthrough approval from FDA. So we're gonna see more in the near future. Thank you very much.
Thank you, Manuel. Nice presentation, and you can see how endobariatric is really evolution and an evolution where it is really contributing significantly, not only to weight loss, but we are really going for metabolic health like diabetes and others. Again, we will leave the discussion to the end and the question to the end. We will go to the next presentation again with our speaker, Barham Ubudaya, who will present endoscopic revision for weight regain after bypass. We finished the primary, we'll go to the revisional endoscopic surgery.
All right, thank you, Professor Al-Qahtani. Thank you, colleague, again for the honor and to be with you to this evening. We're going to talk about endoscopic revision for weight regain after gastric bypass. So these are the trends of bariatric surgery. And as you all know, being predominantly a surgical meeting, that number of sleeve gastrectomy is globally are going up, similar in the US. Number of gastric bypasses are going down, not because the procedure is not good, because it's a bit more challenging procedure than the sleeve gastrectomy. And other procedures like the lap band is significantly decreasing, but what you're seeing that now there's a significant exponential inclines in the number of revision bariatric surgery, which means that there is no cure for the disease of obesity. And we have to expect that there's some weight recidivism and weight regain that happens in the population. This is a study that quantified this pretty good. This is, you could see after the gastric bypass. This is broken down by all patients, those with morbid and super obesity. Everybody loses the maximum weight at about 1 year. And then at the 5 year, there is significant, or not significant, some weight regain in the weight. And at the 10 years, there is continue to be this slow slope of incline. And that is more affecting those who started with a higher BMI. So if you look at the net results, you could see failure rate at 10 years in those with morbid obesity is about 20.4%. In those with super obesity is about 35, or it's about 35%. So that's not a trivial number of weight regain that happens, even with a procedure like a gastric bypass at 10 years. Undoubtedly, there is multiple reasons that this weight regain happens. There's, of course, the genetic background of the patient. There's environmental and psychosocial factors. But what we're trying to focus on is what modifiable risk factors that we could impact in a peroral, minimally invasive approach to help the patients in conjunction with other modalities to get back on track with the weight regain. So far from the modifiable risk factors, we know 2, which we could help with endoscopically. One is the formation of a gastric fistula between the pouch and the excluded stomach, as shown on this figure. And the other one is a dilation of the gastrojejunal stoma, as shown here. So the association between the diameter of the gastrojejunal stoma and weight regain has been shown in multiple large cohort series. This is one from the Cleveland Clinic, and the other one is from the Brigham and Women's Hospital. And you could see that both of these show correlation between the weight regain and the diameter of the gastrojejunal anastomosis. Now, the primary weight loss might not be associated with the diameter, but the weight regain and the feeling of restriction is with the long term. And we've shown this quite definitively. This was a blinded study that we measured the stoma diameter in patients blindly, and we administered an eating questionnaires to assess restriction after gastric bypass. And here, what we're showing you is on the y-axis is the uncontrolled eating domain. You could see with the larger the anastomosis, the more the uncontrolled eating, and this is exactly what the patient tells you is, I could now eat double portion regular meal with no restriction, and I'm gaining the weight, and that's what we're hoping to impact. And by the way, this results was even corroborated with adjustment for the BMI. So BMI was not a confounder here; it was truly an association between the diameter and the uncontrolled eating domain. My colleague, Christine Stier from Germany, showed the same thing, but more elegantly physiologically. And here she did gastric emptying scans, and she showed that before the TOR-E, most of the meal through a dilated gastrojejunostomy rapidly dumps into the small intestines, as you could see here, with very little of the meal staying in the gastric pouch, as shown in this white circle. What happens after the TOR-E, there is more restriction, so the meal slowly empty into the small intestines, and there's a significant portion of the meal that stays within the pouch, and that's what the patient described. They described that their restriction feeling is better after this reduction. Weight regain has definitely a significant negative impact on the quality of life for the patient, and we've shown this in this study published in British Medical Journal Gastroenterology a few years back. So how safe is to intervene surgically for weight regain? That means how safe is it to revise the gastrojejunal anastomosis surgically? And we have literature to guide us. And this is a large cohort study that compared primary versus revisional row-wide gastric bypass. You could see that death is not different. However, ICU stay percentage is doubled. Readmission in 30 days is almost tripled, or more than tripled actually. And post-operative leaks, which is very important, went from a rate of 1.2% for the primary procedure to about 11% with the revision. So revision, surgical revision is not a simple ordeal for the surgeons or the patient. So what endoscopic options do we have? We have multiple tools that we could use to revise this anastomosis and decrease the gastric pouch. The most commonly used is this overstitch endoscopic suturing device, which performed the procedure through a peroral approach. There's other options, including argon plasma coagulation through a series of multiple application over 2 to 3 procedures in order to induce scarring and reduce the size of the anastomosis. And that the USGI incisionless platform through the ROSE procedure uses the smaller plication in order to introduce plication around the gastroduodenal anastomosis in order to do this revision as well. Most of the literature is we're using the overstitch and some of the APC. Therefore, the focus of this talk would be on these modalities. So this is what we're talking about as far as what could we do. You could see here, this is a reduced anastomosis. This is the imbricated suture line. This is the anastomosis before, and this, what we could do endoscopically, is quite remarkable, at least in the immediate term, to reduce the anastomosis to about less than a centimeter in diameter. So there is a randomized controlled trial in this field. The randomized controlled trial happened with a device that is not full thickness suturing, but it was the EndoCinch device, which uses suction-based mucosal suturing. Nonetheless, even with the suction-based mucosal suturing, we could see that compared to sham, the percentage total weight loss is much better. Percent weight stabilization at 6 months. Remember, these patients are gaining weight. So in the sham, 77.8% continue to, or at least a third continue to gain weight. In the procedure, 96% stabilized the weight regain, and achieving more than 20% excess weight loss at 6 months was double in the superficial TORE procedure using the old EndoCinch device, compared to the sham control, which was 14.8%. Nonetheless, this was a proof of concept that the revision of the gastroduodenal anastomosis through a peroral approach is effective compared to doing nothing. The key here is intervening early. Again, this is from the Chris Thompson group, that they show that if you intervene early in the course of the weight regain, rather than waiting until the patient gains all the weight back, the outcomes is better. And that's the paradigm, is if you start seeing weight regain in the patient, intervening early, stabilize significantly the weight regain and give them back a stable trajectory to maintain the weight loss at up to 3 years. Also from the Chris Thompson group, they showed that the results at 5 years with the overstitch device for endoscopic suturing for gastric outlet reduction after ROI gastric bypass is durable, and the proportion of patients achieving more than 5% total body weight loss was maintained at more than 50% even at 5 years. We've recently published in GIE, a large meta-analysis, and you could see the numbers are large. So this is no longer a practice that is case series and case reports. We now have randomized trials, and we have very large cohort series. So here we see this is 737 patients that had a full thickness overstitch TORE procedure versus 888 patients that had the APC version without the suturing. Now, the caveat here is the overstitch is a one procedure rather than 2 or more procedures with the APC. So keep that in mind when we talk about the results. But at 6 months, there's about 6% total body weight loss in the sutured TORE versus 9.5 in the APC. But this is again with 2 sessions rather than 1, so 2 endoscopies. And you could see this is the reduction on of the anastomosis before and after. So to me is, though the TORE is definitely an excellent, I thought the durability could be enhanced by using what we know from endoscopic gastroplasty in order to do an endoscopic sleeve gastroplasty sequence, which is this U-shaped suturing in the pouch, in order not to rely on the anastomosis for the durability, but now rely on the pouch to create a tubular outlet, as shown in figure C here, rather than just reduction of the anastomosis. The advantage is the gastroduodenal anastomosis tends to like to dilate to the size of the jejunum distal to it. So by going in the pouch and creating a tubular exit of the pouch using a sleeve gastroplasty approach, we thought that the durability of the results would be better and enhanced. And we did show that in a large cohort of 96 patients subjected to the tubular TOR-E. That's the way we do the procedure nowadays, is everybody gets a tubular TOR-E procedure versus 35 who got the standard TOR-E. And what we could see from these results is that the durability in blue for the tubular TOR-E compared to the standard TOR-E in the yellow, you could see at 24 months and at all time points that the percentage total body weight loss and the durability of the response is much better with the tubular TOR-E rather than the standard TOR-E. And as such, we submitted this for presentation, and that's now our standard practice is the tubular TOR-E, at least at our center. We took this a step further, and this is now submitted under review in gastro, is we're looking at not only a tubular outlet with the gastroplasty sequence, but to enhance this with what we called as auscultating circle gastroplasty. What I mean with that? I mean, if we could get muscular to muscular apposition, the durability of the configuration hypothetically should be better. So what we're doing is a series of EMRs, again, about 1 centimeter or 2, not at the level of the gastroduodenostomy, but in the pouch as seen here. Then what we're doing is we're using this U-shaped suturing that we do for endoscopic sleeve gastroplasty in order to approximate these circles together. So once the U-shaped suture is cinched, all these circles are going to accordion and be stuck to each other to enhance the healing and to enhance the durability of the response. Here we're showing immediately after we cinched that outlet. And here I'm going to show you the results at a month later. That shows really very good. This is before, this is immediately after. And now if you look at a month later, you will see that the patient lost significant weight, but more importantly, you will see the durability of the response. And here you could see the outlet is very nice. The suture is embedded within this fibrotic approximation of the muscle. And you could see that this is now a significantly reduced outlet. So in summary, a dilated gastroduodenal stoma after OI gastric bypass seems to be an independent risk factor for weight regain. Endoscopic revision can reliably reduce the gastroduodenal stoma and pouch in a minimally invasive per-olar approach with excellent safety and good efficacy. Incorporating TOR-E, or now tubular TOR-E, at least in our practice, early in the management of weight regain, in addition to a multidisciplinary team program, results in the best outcomes. And with that, I will conclude and thank you all for your kind attention.
Thank you so much, Barham. It's really great talk again. And we can see now it's endobariatric is working in primary, it's working in metabolic, and now it's working to some extent in bypass revision. And we will see it now in sleeve revision. So we will talk now about using overstitch or endobariatric for sleeve, post-sleeve for weight regain. We know, as the team has presented many techniques in terms of endobariatric and ESG or overstitch technique. As you can see here, we go in and we take bites in the wall of the stomach for those who are not familiar with the procedure. And then we tighten that part to create a sleeve-like lumen. Yes, there may be the sleeve is something as a name should not be used, but that's what it looks like, a sleeve. And the way there are multiple suturing patterns, there are different studies to show whether the patterns matters or not, but at least there are different patterns. Currently, we use what is called a square pattern. So we go from here down a little bit to the pylorus and go. Whether in primary or revision, the revision will dictate your orientation on your pattern, because not all sleeves are symmetrical. You'll find a lot of twist and a lot of pouching. So you try to create a new symmetrical sleeve. This is the way it looks from outside. if you go, the helix will go and the stitch will go inside, and it's full thickness. So no doubt it's full thickness. When you are dealing with a sleeve stomach, yes, there will be adhesion, there will be a thickening of the wall, so that will make it maybe easier. We didn't find a major difference in terms of pulling the switcher or tightening the switcher, so that doesn't make, honestly, we feel safer in a patient with revision ESG, endoscopic gastroplasty post-sleeve. Currently, we have done primary procedure in 3,200 patients, and the results, as Barham presented, is really almost 60% excess weight loss, and that is 15 total weight loss. And this is up to 5 years, 3 years, you can see up to 15% total weight loss. It has been also almost close to banding and less than sleeve. 5-year study has been shown by Reem Sharaya. It's reaching up to those who maintain 15% weight loss, total weight loss is good number in this study. When we compare, and this study is under progress, we're comparing the sleeve to ESG. I'm talking about primary now. And this is 11,000 sleeve in our center compared to 3,200 endoscopic gastroplasty. The difference is, as you can see here, almost talking about 22% total weight loss in 2 years compared to 15% total weight loss. So yes, it's less than sleeve, but it is, when we compare non-inferiority, it's not inferior to laparoscopic sleeve gastrectomy, considering that non-inferiority is 10% difference. The adverse event is not really major, and most of them are really minor and can be overcome easily with different protocol. When we talk about weight regain and ESG in endoscopic gastroplasty and weight regain, it's another issue that I think it should be in our hand. And we define weight regain as 20% of maximum weight loss. When you gain this amount, this is at least the commonly accepted definition, but there are a lot of definitions. And there are a lot of papers to show that whether sleeve or bypass, they have the chance of weight regain, significant chance, reaching sometimes to significant numbers. And most of them will, or those who have weight regain, will undergo some type of revision. And the revision can be surgical or non-surgical. If you look to different scenarios, when you are faced with weight regain, post-laparoscopic sleeve gastrectomy or sleeve gastrectomy, you will have definitely the dietary and exercise modification, pharmacological approach, endoscopic intervention or endobariatric, and then surgical. Obviously, most people will go to less invasive, and we gave it as a ladder approach. This is the way we do it in patient. This is a post-sleeve. And you see, as we say, there are different size and different symmetrical changes. But eventually, you can create a narrow lumen like this, post-LSG. This study is a multi-centric study with Barham and our colleagues from different centers worldwide. And we found that up to 81% achieve more than 10% total weight loss at 1 year time. So there is a very good, most of them, they are reaching 14 around this total weight loss, but at least 81% more than 10% total weight loss, which is the definition of success in this procedure. There is another paper from Diego, our friend Diego from Dimora and his team in Brazil, and showed almost same result. This is how it looks post laparoscopic sleeve gastrectomy, and you see dilated stomach. Upper GI study is not always accurate, but this is one few, and this is when you see it dilated, or at least there is a good size sleeve, and you can tighten it with endoscopic gastroplasty. The upper GI, there are some important points we would like to mention. The upper GI is not sensitive. Maybe you should rely on endoscopy better. The space is limited and less symmetrical, as we said, so you should be manipulating your procedure inside. and weight loss definitely less than those in a primary patient. We created this algorithm for our patient in the clinic. When we have a patient coming with weight regain post-LSG, we go into their BMI first, and we see what happened to it. Is it really surgical indication to start with, or non-surgical indication? And then we go to contributing factors. What about the patient preference? What about the patient behavior? Do they have GERD or no? These are important factors to make a decision with the patient. And then we look to the size of the sleeve. Is it big or small? And if it is really not candidate for surgery and it is small sleeve, we'll say, look, there is no choice. We cannot do into bariatric. We have to go to diet and behavior and maybe medications. If it is moderate size or big size, then we consider ESG. When the weight is allowing for possible surgical option, then we introduce the surgical option along that. And we say, yes, you can go for a sleeve, you can go for ESG, you can go for bypass, you can, or those who are small and there is no option, the only option to offer them is bypass, apart from medication and behavior. So this is the algorithm that we are adapting. Again, patient is part of this decision making. In conclusion, ESG is an effective and safe primary weight loss procedure, as has been shown, and now we have the randomized study coming out. And ESG serves as a middle ground solution between lifestyle and behavioral modification and bariatric surgery. Endoscopic revision post-LSG is safe and effective, can result in up to 15% total weight loss in 1 year time, which is corresponding to 60% excess weight loss. And it is better and safer to consider less invasive measures and revisional intervention before going for major surgery, revisional surgery, knowing that the complication of surgery. Thank you so much for this. And I guess I'm both a dual hat, so I will go for presenting the next speaker. And this is the next presentation is Contrad Lopez Nafa. Now, his fellow is presenting because he has to leave, and he will give this talk. Go ahead, Ravi.
Can you hear me?
Yes.
Thank you, organizers. Thank you very much for inviting us for this excellent meeting. I'm Dr. Ravi Shankar Ashokkumar. I'll be presenting on behalf of my team, Professor Gontran Lopez Nava, on researching after endoscopic sleeve gastroplasty. Obesity is a silent pandemic that has expanded, involving across the globe a vast majority of people, and even in the Arabian world, the prevalence of obesity has been exponentially increasing. We must know that obesity is a chronic disease. Hence, the management of obesity is something similar to other chronic diseases like hypertension, diabetes, and cardiovascular disease. And the most worrisome thing is a large proportion of patients are either dying because of obesity or obesity-related comorbidities. Hence, when we approach obesity, there is no one treatment that is shown to be superior in terms of achieving cure. We are just trying to help these patients achieve their weight loss and manage their long-standing comorbidities. Thus, we have to approach obesity management as a chronic disease. When we look at the available treatment options, there are several programs which help patients achieve their weight loss. Some of the patients try on their own, and some enroll in a structured commercial weight loss program. But what we see is all these patients lose weight, but at one point they start to bounce back. Typically, after diet and lifestyle modifications, we can see at about 1 year, their weight starts to go up. Is it something particular to just diet and weight loss? Unfortunately not. Even in the bariatric surgical group, as previous speakers including Bagham and Al-Khatani highlighted, we can see that bariatric surgery induces significant weight loss. At about 24 months, we notice that despite the type of treatment that the patient has undergone, a bouncing of their weight or regaining of their weight is bound to happen. Especially here, we can see with diet, at about 24 months, patient starts to regain their weight. And even in bypass, we can see the weight slowly starting to go up at about 24 to 30 months. The most important thing is to offer these patients a treatment option that is sustainable over time. But unfortunately, even with laparoscopic sleeve dilatation is an important problem. At the imaging studies looking at the size of the sleeve serially has shown that at about 1 year, 60% of the patients experience dilatation in sleeve. And now we are talking more and more about revision of bariatric surgeries. And at 5 years, we can see that Roux-en-Y bypass shows dilatation of gastrojejunal almost 20% of the population experience dilatation of gastrojejunal anastomosis, leading to increase in weight regain. So as we can see, any treatment that we offer to these patients in terms of revision has to be safe and easy for the patients to accept. With the current option of offering a revision surgery, we know that the risk is greater than the primary surgery. The complication rate with laparoscopic revision is up to 33%, and with open surgery, the complication rate even goes up to 47%. As Barham has highlighted in his previous slides, we can say that the hospitalization stay increases and there is increased risk of leaks. More importantly, we must understand that subjecting these patients to complex malabsorptive procedures puts them at risk of protein and vitamin deficiency and malabsorptions. And in long run, with repeat surgeries, there is a chance that they may develop psychiatric illnesses as well, they like depression and so on. So, in the last few years, the technique that has attracted the most is endoscopic sleeve gastroplasty. The main reason for its increasing attraction is because of the ease of the procedure, a good weight loss profile, and a shorter hospital stay. The technique essentially mimics laparoscopic sleeve. It tries to create a tubular stomach, except that it does not involve the fundus. So what do we know so far? We performed our meta-analysis comparing endoscopic sleeve with laparoscopic sleeve at about 1 year. What we know is the weight loss is around 17% from 8 studies. It's slightly lower to a laparoscopic sleeve. It's understandable because this procedure does not involve any resection of the stomach. But however, what we noticed is the rate of adverse events and development of de novo GER is lower with endoscopic sleeve compared to laparoscopic sleeve. We went on to next step to compare the weight loss efficacy of endoscopic sleeve at 2 years between its counterpart laparoscopic sleeve and laparoscopic great application. We can see here that endoscopic sleeve procedure can be performed in a relatively shorter time. Our usual procedure time is around 35 to 40 minutes. The weight loss at about 2 years is 18.5%, which is inferior to laparoscopic surgical procedures, which is understandable, but the complication rate is very, very low. These patients recover very fast and they can be sent home the next day without the need for prolonged hospital stay. But when we looked at our own results comparing endoscopic sleeve with laparoscopic sleeve gastroplasty and greater curve applications published in endoscopy, we can see that similar to other published studies, we start to see the weight regain happening typically at about 18 months to 2 years. Despite an initial good weight loss, we can see that weight regain is bound to happen. Then again, we must be mindful that we are dealing with a chronic disease. The management of chronic disease is going to be like continued reinforcement, continued treatment rather than one treatment that can bring in a cure. So any intervention in this group of patients need to be very safe and less invasive so that it promotes more patients to even seek help if they experience weight regain. So in our experience, we noticed there are three different class of patients, pre-ESG who come for weight management issues. One is weight loss failure. These patients fail to lose weight despite the primary ESG, and there is weight plateau and weight regain group. Similar to bariatric surgery, we defined weight loss failure as those patients who fail to achieve more than 10% total body weight loss at about 6 months. As we can see, the drop in their weight is lower than expected. And the weight plateau group, on the contrary, have achieved more than 10% total body weight loss. But the issue with them is after they hit the nadir, they just maintain there, but they don't continue to lose further. And the last group is the weight regain group. This is the good responders. They have actually responded very well by achieving more than 10% weight loss. But with time, what happens is they bounce back by regaining 50% of their lost weight. So in our own experience, treating more than 480 patients, we found that close to 35 of them required re-intervention. The re-intervention which we offer here is resuturing or a repeat endoscopic sleeve gastroplasty. We noticed that the weight failure group indeed had a very low percentage total body weight loss compared to the good responders, which is the weight regain and weight plateau group. They almost lost 20% weight loss, which is good enough to see improvement in comorbidities. And second thing is the time. There is actually a time lag between when the patients actually come to you. Especially those patients who had weight regain, they came to us typically at about 2 years compared to weight plateau and weight loss failure, which you intervene at about 1 year's time. The most important thing in this is follow-ups. Those patients who don't come for your multidisciplinary follow-up are bound to not achieve the weight loss that you would expect it to achieve. As we can see in the weight loss failure group, their number of visits to the multidisciplinary team was lower. So when we performed endoscopy in this group of patients, what we actually noticed is, especially in the weight loss failure group, we noticed the sutures are completely dehisced. The sleeve orientation is no longer maintained, and we can see that all the transmural sutures have kind of like given away. And in some group of patients, we do observe partial dehiscence, which means you still see sutures holding the tissue. To some extent, the sleeve configuration is maintained, but majority of the sutures that are proximal have opened up. In the last group, which is indeed a small portion, what we see is there is like suture mucosal tags from the suturing edges. We can see nice mucosal tags maintaining a sleeve-like configuration still. This percentage of patients are relatively low, and what we notice is the suture dehiscence in most patients. So what we do in this group of patients is we repeat our endoscopic sleeve. We use the overstitch device, and then we go in. We don't remove any of these sutures. It's not required to cut these sutures. We can just continue our endoscopic suturing. We just take bites slightly proximal to the previous suture. It's like a reinforcement bite. We still follow our U-shaped suture pattern, and we bring all the tissue in. There is not that much adhesion that develops after endoscopic sleeve, so it's pretty easy to grab the tissue and get into your suturing device. So here we can see that after our revision procedure, the sleeve configuration is brought back again. And when we looked at the post-ESG outcomes, we can see that the number of sutures that we actually require to do a redo is ESG is around 3. The percentage total body weight loss, even after ESG, is all patients continue to lose weight, irrespective of whether they are weight loss failure group or weight regain group. The key is the good responders for ESG is yet to be decided, but based on our observation and experience, we think that weight regain and weight plateau group would actually benefit from ESG compared to weight loss failure group. The issue is with weight loss failure, these patients to begin with are non-compliant. Offering them a repeat procedure, the likelihood of it failing is in fact higher compared to the other two groups. So in our cohort of patients, we did not encounter any technical difficulties. None of them had any complications. The procedure duration was not longer. It's exactly same like the primary procedure. And patients actually can be discharged on the same day or within 24 hours. The medication requirement for both nausea and pain is not excessive. Most of these patients are the most required medications for a week, after which they got back to normal. The recovery is pretty fast. By third day, most patients experience no symptoms. So what causes suture dehiscence is the frequent question that gets asked. Most of the time, the durability of sutures is also determined by patient's compliance. If the patients resort back to eating bigger portions, not comply with the dietary changes recommended by the dietitians, then you're going to increase the intragastric pressure, which kind of like stretches the sutures and makes the sutures cut. The second aspect is the aspect. When we create a very tight sleeve, the pressure is high and it is bound to break the sutures. And there are issues with the type of suturing. Sometimes if we use a less number of sutures, or if we don't perform consistent full thickness suturing, then the suture cuts through the mucosa and opens up the stomach. In our practice, we typically use around 5 sutures to reduce the stomach for a primary procedure. And lastly, we don't know whether the suture durability would partly be reduced also because of the acidic milieu in the stomach. And in endoscopic sleeve, we are not cutting down the blood supply or neural innervation, so the stomach continues to move significantly, and this by itself in a tubular stomach would increase the pressure and break the sutures. The future of endoscopic sleeve is, we know that endoscopic sleeve at one point opens up. So this needs to be upfront discussed with the patients, and most often for patients who are on the higher BMI, and a stage treatment would be an ideal option, which would be performing sequential endoscopic sleeve gastroplasty at 2 or 3 years after primary sleeve, depending upon their response after primary sleeve. The second option is the resuturing can be done using the new primary obesity surgery endoluminal 2 device. We know that the suture applications are durable from our publication in endoscopy. From our own experience, performing post-2 procedure as a revision option for ESG has been promising so far. And recently there is increasing availability of once a week GLP-1 analogs. And the recent publications on combining ESG with GLP-1 analogs have been very promising with a good weight loss results. I think that would be a good option for us to consider when managing obese patients. With that, I thank everyone for giving us this opportunity. Without our team, this publication wouldn't be possible. Thank you very much.
Thank you, Rafi. Thank you for their presentation. Next talk will be with Manuel Galfao, endoscopic management of bariatric complication, which we always need this type of in our practice. Manuel.
So my next presentation will be about the possibility of treating complications of bariatric surgery by using endoscopy. And what I have prepared to you is one presentation about the complications of a sleeve gastrectomy. So this is the team I probably work with that make my job looks good. And we can intervene and we can help in complications of sleeve gastrectomy, bypasses, and bends. Pretty much the bariatric endoscopy has developed to help the surgeons in a very broad way. And I always wanted to start in my presentation saying the bariatric surgery is as safe as a lap chole, and nothing that you're going to see from now on will contradict it. So the number of complications are low, but they exist, and we try to help by endoscopy. So why using sleeve gastrectomy as a model to talk about complications? Because actually it behaves very differently and demands our special attention. And the topic of endoscopic treatment of complications, they are very broad. We cannot exhaust it in the allotted time. So why is sleeve gastrectomy so different? So let me guide you through that. So this is a high resolution manometry images. So as you see on the left, you see the superior collar bar horizontal, and then you have an inferior collar bar and then represent the upper esophageal sphincter and the lower esophageal sphincter. In between, you have the swallowing or the peristaltic wave. So what you see here is less or more blue, less pressure, more to red or dark is more pressure. So you can see here that below the inferior color bar is the stomach. It is blue. So stomach is a low pressure system that is high compliance. So let's take a look to the graph on the right of your screen. And you're going to see that below the inferior horizontal color bar that is pressurized. So that means in this is after the sleeve gastrectomy in the same subject. So you can see here that the sleeve gastrectomy increases the pressure of the system, and we have a weak spot that is the his angle. So let me try to guide with this cartoon. And that's when you build the sleeve gastrectomy, something can happen between the body and the antrum. So impacts on the pressure up high, and then you have the weak spot, and it leads to the leak, and also make these leaks with a tendency to become chronic. So there are other ways to show that. There's a very recent paper from Italy, from the bioengineer. So they make models of different kinds of procedures on a bench, and they fill it with a determined amount of liquid, and they could measure the pressure. So if we go and see here, the sleeve gastrectomy one come from green, from yellow, and red. So there's a large increase of pressure. And if you compare with the model of endoscopic sleeve gastroplasty, it doesn't happen, and doesn't happen also in the bands, gastric bands. So what we have to offer to help when the leak happens. So we can see here on the screen that a lot of tools that we can use. I'll try to guide you to what it can be done in each situation, and with the armamentarium that we have to go after that. So we use a classification that was defined in this consensus panel that we had take part of that. That's kind of old, but just to understand, there is more than 700 citations of this paper since 2011, and this classification was defined in acute, later, acute, later, and then comes the chronic part of that. So the first thing we use is their stents. So this the old one, and this more ready available to do that. So if you just understand the use of stents, so like this meta-analysis done in São Paulo University that end up evaluating 28 articles. And you can see here that the trouble begins with so many different names and types of stents here. But doesn't matter if you use any kind of stent, the overall healing rate is 72.8% in those 187 patients. So leak site, as we expected, is up high. So 94% of the leaks are proximal on that. And also the use of stents is very well defined here. And you can see here that is used for this acute and early leaks. So you can see here, if you put them together, is more than 80% of the cases. So it means that as more chronic the case is, less effective the stent is. So the other thing is, you can see here the mean of stents per patient is 1.4. It means that you have to pay attention after you put the stent. So you have to follow your patient. At each other week, you have to check your patients with X-ray to see if the stents had dislodged or not, because the Achilles tendon of the stents is migration, as you can see here, 28% of those. And this study was done basically with esophageal stents, not specific stents that we have right now. So as a meta-analysis, you see here there's no perforation cases, minimal bleeding, no death reports. Why? Because the meta-analysis, they lose the case report. They don't get the case report of 1 or 2 cases on that, but we know that it did exist, so we're going to explore it later. So what happens if we use a very specific stent like this one we have designed for us, and we did a series of 20 patients, and we could heal all of the leaks on the sleeve gastrectomy. They were early, and acute leaks with this specific stent, but this was a tertiary center dedicated to bariatric endoscopy, as you can see here on the publications on that. So the idea of this bariatric stent is to close the hole, or occlude the hole and pass the incisura. It can be positioned pre-pyloric or transpyloric way all the way. And then what happens when we brought the use of those specific stents? Now they are those Korean stents. They are very sophisticated ones, and we put centers that are reference center, and then centers that use once in a while. So you can see here, letter A, you can see the cavity on the left, and then the lumen on the right. Then on B, you see the X-ray, the contrast going outside. And then you see letter G, the stent in place, letter D, the stent open, letter E, that we isolated the leak with the stent. And you can see here also another case from A, B, and C that we put the stent and we can correct it. But you can see here clinical success of 78% and looks very nice. But if you dig that, those patients have quite some symptoms and quite some complications. So you can see letter A, what you're seeing is the mediastinum of a perforation. Letter B is the stent on the bowel, and letter C is the surgery needed to remove the stent. Letter D, what you see more yellow in the middle, is a contained perforation. Letter E is a distal ulcer, and letter F is a submucosal abscess that was treated by AUS. So complications can happen and can be very severe, like this one coming from France with 5 patients that had aortic injuries following stents. To highlight that those centers, they didn't follow the patients closer as it should be, but it is, the stents have to be, they are good too, but have to be used wisely on that. And then comes the new one, that's the pigtail, the double pigtail done by endoscopy, an example of how we do that. So you see the sleeve, the leak, and the narrowing. And then you see the pigtail the way it should on the cavity, and then it drains to inside the lumen, a very anatomical drainage, as you can also see here, and get the 3-dimensional reconstruction. So it's a very elegant way. So let's see this systematic review. And you can see here 9 papers, most of them coming from France, 681 patients with very low complication, 13.73%, most of them not severe, an impressive 84.42% success rate. And one of these authors, we know that they are about to present a series with more than 1,000 cases. So it's easy to do that. You use a regular scope, you put a guide wire, you slide the pigtail inside, and you the proximal part on the lumen. So it's pretty much standard. Then comes a new kid on the block, the EVAC. It was designed to contain septic disaster in mediastinus in the lower rectum with anastomosis decens, but there are some groups using for endoscopy. And the idea is that you put a sponge, attach it to a nasogastric tube, and then you outside do a vacuum and it heals. So the first studies specific for that, they were done with traditional sponges, but you can see here 10 procedures per patient, 50 days on the hospital, but with good resolution on all the cases. And it will depend on the structure of your hospital. So if leaving the patients in the hospital is not a big challenge, it is okay to do that, although taking consideration the patient have to be in the hospital because they have the tube attached to the vacuum. And then there's a group in Brazil, Dr. Flaubert, our friend, that developed another way to do that alternatively, that don't use sponges, you use a 4x4 gauze and then a plastic covering that, multi-perforated, and it can stay, instead of you have to replace each 3 days, you can replace each 7 days, and you can put it on the lumen or inside the cavity, and it's a very cheap alternative to that. And you can see here that there's some groups that use the idea like this one, and you have here, look at the picture on the left, the arrows, and you position on the lumen, it apply the vacuum, and also they have the advantage that they have a distal robot distal catheter that you can feed your patient. So that is progressing. There are some groups doing that, and look at this case, how it changed from 10 days in the hospital to 50 days in the hospital to 10 days of the therapeutic, the evac, from 10 procedures to 3 procedures, and a clinical success of 87%. And then there's a technique that we have developed in Brazil that's called septotomy, that use it for chronic cases. So if you ever see a chronic case of a sleeve leak, that's always a septum dividing the cavity and the lumen. And the septum is basically the staple line of the surgeon. So the idea is that you go there, you cut it until you level the cavity, and then you aggressively dilate this sleeve with another technique we have developed that is achalasia balloon dilation from those types of problems. And then it will reroute the path of the food in a way that the leak gonna heal. So that's the first cases we present. And now a very recent one that was published, that they use this for late leaks, as you can see, the inferior right quadrant, and they have success. And as this technique progressed, that we are more aggressive on cutting the septum, you can see here the operative time is very acceptable, that they could do all the cases in one session, and only one case they need to do a reseptotomy to do that. So those results are very reproducible, despite of small series being presented. And also we have the endosuturing. So why not using the endosuturing to close the leak? So it is because the nature of these leaks with a high pressure system, but we can use the suture to suture those stents in place, because they had a problem with dislodgement and can be solved with that. There's some publications on that. Also, we have the over the scope clip. That is a very attractive option to do that, but for the reasons I explained of the high pressure system, this seems to be clouncing on that. The initial results were promising, but we can see here that later on, with more experience, look what happens on that. So 26 patients, they apply over the scope clip, end up on 11 patients needing a major surgery like esophagojejunostomy to do that, meaning that the clips didn't really work on that. And then comes this later very interesting option for chronic leaks, that using a cardiac occluder, as you can see here on this publication from our friend Alberto Batista from Venezuela. And if you take a look here, for sleeve gastrectomy, 31 patients, they had used in chronic cases with very good results. Most of those cases were gastrobronchial leaks to that. So in summary, those are the techniques. You can occlude, you can internally drain, you can apply vacuum for that, you can block. And there are different ways how it works or not. And as there is no flow chart, there's no clear, unbiased algorithm, we're going to give you our personal experience in how it can be used or not. So for acute and early, stents, as much acute as it is, stents are good. So a little bit down the road, pigtails can go that with a minimal adverse event and even evac. Later, for later leaks, septotomy and occluder or evac goes in that direction. If you want to use high tech with a higher price, the stents and the occluder for sure. With low tech, lower price, the pigtail, the septotomy, and the evac. So you choose based on the expertise available, the availability of technology you have. Easier for the patients, definitely the pigtails, the occluder, and the septotomy. Harder for the patients, the stents and the evac. The stents because they expand and the patient have a lot of symptoms and reflux, and the evac, they are attached to the nasogastric tube and to the machine that beeps. So if you target a brief hospital stay, pigtail, stents, occluder, or septotomy. If you your system allowed to a longer stay, and the trade-off is the evac for sure. So the message is the endoluminal treatment of leaks, they are complementary, they are not competitive. There's no such thing of the best one. Sleeve leaks are always complex. So imagine that you're gonna have to use more than one solution for that. And also look for strictures and kinks, they have to be solved in order to get better results. And there is a clear need for unbiased algorithm that we don't see in the literature up to now. So let me show you a case. So you can see here a clear leak, fluid go inside. So we are starting the septotomy and we are cutting the septum. So the lumen is on the right side of your screen and the cavity is on the left side. So the idea is that you can cut with APC. In this case, we are using a hook knife that is a cautery to do that. And you can see here that we can go in a very safe manner. And you cut until you see the base of the cavity. And sometimes you encounter clips, suture that they have done that. And you can just go there. And we will combine techniques here. So then we pass an achalasia balloon. We aggressive dilate it, so look at how it corrects the axis here. And you can see here from a light color that balloon expanding. And now the mucosa, you look right inside by endoscopy, is very pale, so there's a lot of pressure to do that. And we do that to take down the pressure. So take a very clear look. We could cut all the septum on that. And now, instead of just doing the septotomy, what to do, we combine technologies. So we are putting the guide wire, and over the guide wire, we will slide the pigtail. And once we get this part inside, we remove the guide wire, so it will curl both ends on that, and we are seeing the distal end of that, the proximal end. And what we do, generally, we grab the proximal part, and we put inside the lumen with a grasper. So it assures us a good drainage from up, down, to top, to bottom, as we are about to see here on the X-ray. So that's a way we do it nicely. So new techniques are coming, like this one that is called X-Tech, that apply techs like the techs you guys surgeon use for hernias and attach it to suture. So there's an example. It is a peg that's with a chronic fistula. So you go there and you leave this corkscrew-like pin, attach it to a suture, and you can go, it comes with 4 tags that will go over the edges of the opening, as you can see here. And you just recharge outside, go inside, apply that. You could do here, this is a figure of 8. That's the last one. And at the end, what you do, you use a cinching mechanism, so you can put it all together and apply a clip, so we can do that. So we don't know if it can use it on that situation or not, but I think it's worth to explore those new technologies that are coming from that. So that's what I have to tell you about these, and we can go with further details, and we can clear doubts on the Q&A part of the session. Thank you very much.
Thank you, Manuel, for a great presentation. Now it's a pleasure to invite our next speaker, who will really, I've seen him doing the procedure, and it was very impressive the way he's doing it, because it will solve a lot of our problem as surgeon when we have a problem with the sleeve and like narrowing or stricture at the incisura or a twist or something like this. Eduardo de Moura, Professor and Director of Gastrointestinal Endoscopy and Surgery at the unit of Faculty of Medicine, Sao Paulo, University of Sao Paulo, Brazil. Eduardo, a pleasure to have you with us, and thank you for accepting our invitation.
Thank you, Alcatani, for the kind invitation. I'm very happy to participate in the very important Congress. Congratulations for the event.
Thank you.
In this presentation, we'll cover the topic management of post-bariatric stricture, from simple to complex. We will try to convey our personal experience. I declare no conflict of interest. We will address not only the stenosis themselves, but also the condition that can lead to luminal obstruction. I believe that the appreciation of clinical manifestation suggestive of obstructive symptoms is fundamental, along with endoscopic and radiologic aspect. Anastomotic stricture usually appear on upper GI studies as short segment of smooth narrowing at the gastrojejunal anastomosis. If obstruction is present, the gastric pouch may be dilated and empty of barrier into the root limb may be delayed. Upper GI examination typically reveal a long tubular gastric pouch in patients with a laparoscopic sleeve gastrectomy. About the ring slippage. When there is a displacement of the ring causing obstruction of the foot loop, there are two possibilities for the treatment. The use of 30 millimeter pneumatic balloon or the placement of a metallic or plastic stent. The ring slippage used for pneumatic balloon dilation. The contraindicate to the use of a balloon is related to clinical and or local manifestation that indicate tissue ischemia. Technical and clinical success is closer to 100% and no recurrence. About the stent, plastic or metallic stent. The use of a self-expanding plastic stent is a very refined technique with a high success rate, but with some risk of migration and post-procedure stenosis. Regarding the erosion of the ring, usually it is not related to clinical significant obstruction, although this is possible to occur. The treatment is quite simple. It uses scissors, and when a mesh was used as a ring, the most appropriate technique is argon plasma coagulation. In the extrusion of the gastric band, the technique to remove it is by the use of conventional lithotripsy. Technical success is very close to 100%. Although rare, the risk of complications such as high hypertensive pneumoperitoneum must be kept in mind. This moment in the video I use for the lithotripsy and cut for the band and remove the band using the snare. About the gastrojejunostomy anastomotic stenosis are more common post-gastric bypass with an estimate incidence rate remain unclear and is likely multifactorial. Tissue ischemia caused by the stapler, anastomotic tension, edema, and even foreign body reaction are believed to contribute to development of anastomotic stricture. About the hydrostatic balloon dilation, gastrojejunostomy anastomosis stricture, common complication in the early postoperative period. Endoscopic dilation is safe and effective with low complication rate and high rate of symptoms improvement after one dilation. Endoscopic dilation response is maintained long-term as gastrojejunal anastomosis stricture patients are followed on average for 2 years. About the refractory gastrojejunal anastomosis stenosis. The endoscopic balloon dilation appeared to be well tolerated, and effective ischemic segment and fistula were found to be important risk factor for balloon dilation failure. Sometimes, in this circumstance, the surgery approach is adequate. But in the other hand, I have other possibility to treat this complication. In recent published literature has suggested safety and efficacy of lamps for management of gastrojejunal anastomotic stricture. And this stent provides us with an alternative to self-expandable metallic stent. 36.4% of lamps placed at anastomotic stricture require re-intervention, and rate of migration for upper gastrointestinal stricture was 11.1%. About sleeve gastrectomy. Although less frequent, stricture post-sleeve gastrectomy may present a great management challenge. Incidence in patients undergoing sleeve gastrectomy is reported to be between 0.2% to 4%. Possible cause of post-sleeve gastrectomy stenosis development include the use of a small bulge. Post-sleeve gastrectomy stricture commonly occur at the proximal to mid-stomach, in incisura or the gastroesophageal junction. Management of stricture post-sleeve gastrectomy include clinical observation, endoscopic dilation with or without stent, seromyotomy, or ultimately convert to gastric bypass. There are a significant number of publications suggesting an approach algorithm, such as the one published by Brunaldi in 2020. However, we will transmit how we approach in this circumstance. It is important to understand the moment in which we approach, thinking about the healing of the suture area. In the early phase, less than 3 weeks, it is possible to only wait for inflammatory repair. If there is no favorable evolution, endoscopic approach can be offered. Pneumatic dilation is often enough to solve the problem, and it can be done in up to 3 sessions. When the balloon dilation therapy fails, the use of stent can be considered. Stents may also be used in the management of stricture. In a prospective series presented by L. Banks, the authors report an 83% stent success rate in management stricture in 6 patients that have been refractory to repeated balloon dilation. Nevertheless, a common concern of stent application is stent migration, which is reported to occur in 58 to 66% of stent placement. Many colleagues indicated the surgical approach when balloon dilatation and stent fail. We do not agree with this sequence of approach. We are convinced that at this point, we should access the stent of the stenotic segment and whether there is a twisted sleeve. It is important to differentiate true stenosis from sleeve rotation or torsion, which may mimic obstructive symptoms. This may also be management through endoscopic dilation, myotomy, or surgical revision. We propose the endoscopic tunnel-eye structurotomy technique described in 2019. This consists of the section of the fibrosis area in full plane, full thickness, through endoscopic tunnel line, allowing an enlargement of the gastric lumen, reduce of intraluminal pressure, and easier gastric empty. In this video, it's possible to identify the moment that I cut for the mucosa, identify the submucosa area, initial for the tunnel line, identify the fibrosis area, and the stapler line. After identifying this area, I cut for the tissue, full thickness, and identify the abdominal cavity. After I cut for the muscular and the fibrosis, I close for the tissue with clips. It should be considered that when there is an extremely sharp rotation, this technique may have limitations. Only when there is no possibility for this technique, we recommended the surgery, convert the sleeve into a gastric bypass. Now it's possible to identify in this video the pre and post procedure. It's possible to throw the scope easily into the gastric cavity. It's no difficult to identify the pylorus and analyze in the duodenum. Take home message. There is not enough data to establish a precise algorithm for bariatric surgery stenosis. Complex patient, individual approach. Usually more than one intervention is required. Consider your expertise when choose the endoscopic technique, and consider refer the patient to a center of excellence.
Thank you, my friend. Thank you very much.
Thank you so much, Eduardo. Great talk. This is what is really impressive, where you are doing the structuroplasty and some sort of submucosal dissection all the way. I have seen it in real with you, so it's really interesting for us to see. Now we will call on all our speakers and panelists. Please, thank you for joining us today. We'll wait for, we have Imad, we have Barham, we have Abdullah, we Abid, and we have, so now let us, I will ask you, I'm sure you have some question. We'll have the question from audience. I will leave the stage for you, Abid. Any comments or any questions? And then we'll go to Imad, and then we'll take from there. Abid, is this man?
Yes.
Go ahead. Any question, any comment from your side?
First of all, thank you for the event. It was a great, lot of lectures. Seemed to be difficult to gather all important questions, but maybe I have very critical questions usually we ask from our colleagues for Prof. Barham. So do you think the techniques of the endoscopic sleeve, it's a matter for giving us some more result, or sometimes the post-procedure follow-up or recommendation for our patients? But we have some of the center, they don't have a good results, but we have some of the international study now to a lot of good results for total body weight loss.
Yeah, so thank you, Abid, for this question. So the question is, what's the recommendation? Is it the endoscopic sleeve or the post 2.0? So the endoscopic sleeve, the advantage of the sleeve is it's truly a minimally invasive intervention for patients. That means the risks are lower than even an intragastric balloon. The tolerance is lower than implantable. The results as far as efficacy, they're approaching lab band results, which they're good enough. And what we know that nothing is durable forever. So yes, at a period of more than 2 years, what we're going to see from the MERIT trial, we will see that durability is pretty good. Actually, it's excellent up to 2 years. After 2 years, we don't know from the randomized trials at least. But as to any management, I mean, if you have a device or a procedure that takes 30 minutes as an outpatient, preserve the anatomy, better tolerated than implantable devices, and require one single endoscopy, then you have a true value proposition, similar to coronary stenting. Coronary stenting in the heart is not the same as CABG, right? And all the studies showed that the mortality benefit of a CABG, as far as in the disease of like coronary artery disease, is better than the stents, but the stents are covering this bridge gap, and now they're a standard of care. The endosleeve is very similar to that. It's a procedure that's outpatient, well tolerated. Patient could accept it because you're not removing their stomach. And there's a patient who once told me, "Doctor, if I talk too much, do you cut my tongue?" I was like, "No. So why do you want to remove my stomach?" So that's the mindset of patients who are looking for an intervention, is they want the minimally invasive parallel approach. And the endoscopic sleeve has its limitation, but overall, it's the most successful so far endoscopic bariatric intervention that patients gravitate to, they accept it. The literature is quite complete. I don't think there's anything in endoscopy, at least, that have as much literature. More than 5,000 published in the literature, more than 20,000 cases done globally, and now we have a level 1 randomized controlled trial for FDA. So I think the literature is there, patient acceptance is there. Now the post 2.0, it's interesting because it offers a cookbook approach to gastroplasty. That means reproducibility should be independent of the operator, unlike suturing. Suturing is still require the operator to master the suturing technique, to get full thickness suturing, to follow the sequence, and to have a good endoscopic sleeve result. The post 2.0 promise is it's if you do the plication in that location, you will get the same plication whether an expert did the plication or a novice did the plication. So the reproducibility should be an advantage to post 2.0. The plications for 2.0 are more distribution of the force, so the plications are more durable. But the question is, does the durability justify the difference? We don't know yet at this point. What we know is we have a procedure, which is the endoscopic sleeve gastroplasty, that in its current form seems to appeal to patients, does the job as far as reaching more than 10% total body weight loss at 2 years intervals, better than any of the implantable devices, better than medication, not as good as surgery, but it's in between these implantable and surgery, and it definitely have a side effect profile that makes up the difference in efficacy compared to surgery. So I think that would be my answer to this question.
Thank you, Barham. Imad, do you have any comments or questions?
Yeah, well, thank you so much for this great conference, and congrats, Aid, and the remaining faculty. I think I have myself learned some points that are actually very practical that I could apply next day when I'm doing these procedures. However, I had some concerns as I attended the most recent DDW, actually raising the concern. One of the lectures was actually talking about I would rather leave this question to the end, but you know, the shifting in the microbiota and microbiomes after bariatric surgery, and the increased risk of colitis and risk of cancer. They were actually talking about animal models, not really actual patients yet, but now we are moving towards less invasive, more promising, or as promising procedures, including endoscopic sleeve gastroplasties, which gonna come, if it's not already, very popular. Should we really have any concerns moving forward, and how are we gonna actually deal with this and study it more?
Imad, if you allow me just to elaborate on this question, just to understand it more. So what you are saying, bariatric surgery itself somehow might disturb the gut flora and cause some sort of microbiome issues. and that can induce different treatment. Is that possible to happen in endobariatric? Is that your question?
Right, exactly.
So we will ask maybe Barham, you can answer, and then Abid can have a comment, and I'll have my comment. Go ahead.
Thank you, Ahmad, for that question. And I will offer a slightly different point of view. So we know that bariatric surgery has metabolic benefits that goes beyond the numeric weight loss that we see. And these benefits are related to changes in the microbiota, but also, more importantly, to changes in the metabolites of the microbiota. So we see effects on the central nervous system as far as neurodegenerative diseases and Alzheimer's diseases and Parkinson's. We see effects on inflammatory markers, on visceral fat signaling, on coronary artery disease. All these are related to changes in bile acid circulation, the microbiome, and the metabolites that come from the microbiome. Now, this is the beneficial side of the story. You seem to allude to some adverse events related to this changes in the microbiome that could be translated to increased risk of inflammatory bowel disease or what have you. I think nothing in medicine is perfect, and there's risks and benefits for any interventions that we do, but the state of where things are in 2021 is we cannot say that bariatric surgery has conclusive bad outcomes as far as colitis. The literature suggests that bariatric surgery is still the gold standard for treatment of obesity and metabolic disease. It has multiple metabolic benefits that goes beyond the weight loss effect per se, including favorable changes in microbiome profile and inflammatory markers in visceral adiposity signaling. That being said, bariatric surgery is still bariatric surgery, and for some patients, it's deemed as an invasive intervention. Therefore, what we're saying that endoscopy is going to come and help augment the field and introduce anatomy-preserving peroral approaches that complements bariatric surgery for a cohort that does not qualify for bariatric surgery or do not wish to pursue it. Now, whether endoscopy is going to affect the microbiome similarly or differently, it's still too early to say. But at this point, I don't think we have enough evidence to suggest that the changes that comes with bariatric surgery has significant ill effects on humans on the microbiota enough to make us worried at all with this intervention.
Thank you. I think I will echo exactly what you said, Barham. Eduardo, do you have any comment on microbiome and effect of bariatric surgery or endobariatric on it?
I have a paper about this problem, and unfortunately, my result isn't good for transplant or fecal transplant in the population in obesity patient. When analyzed, the initial result is interesting result interfere. But when I repeat the same study after 6 months, 50% come back the initial characteristic, and after 1 year is the same. No, it's not adequate result in long follow-up.
Excellent. Now I will get some question, and then there are some raised hand. We'll get to you and the attendees. Don't worry, we are coming to you. Now from Samah Melibari, is this procedure reversible? Which I think he's alluding to ESG. Does the application would it affect the malfunction of stable line or so? Well, for ESG, being a surgeon, and we have published about it, about sleeve and revisional surgery post ESG, endoscopic gastroplasty, yes, reversible, 100%. You can remove all endoscopic procedure, remove all clips and anchors from there and needles, and you can apply your sleeve or bypass, whatever you want. And for both two, little bit, we face some difficulties because sometimes they are at the angle of his, and sometimes difficult to do it there, but still it can be. It's not as easy as endoscopic gastroplasty. Isam Bataya, thank you. Would you please elaborate more regarding the selection criteria for patients who are indicated for the procedure, endoscopic gastroplasty? Barham.
Yeah, to me, it's the indication is quite simple. Anybody who's overweight or obese who does not qualify for bariatric surgery or refuses bariatric surgery, it's a fair game. That's the beauty of this procedure. The procedure, its safety is quite high. The procedure is quite simple, done as an outpatient, does not burn bridges. So anybody who's overweight, obese, does not qualify for bariatric surgery. Now, I said does not qualify for bariatric surgery, and that means if the patient has a BMI above 35 with metabolic comorbidities, especially type 2 diabetes, I'm offering them first the gold standard, which is bariatric surgery. But if they're refusing that gold standard, there's a price for inaction. I'm gonna tell them, oh, sorry, there's nothing else to offer you. I would offer them the endoscopic sleeve gastroplasty with an enhanced program. Now, if the patient does not qualify for bariatric surgery, that means their BMI is less than 40 with no comorbidities or less than 35, then it's the first go-to procedure, even before I try medication or anything else, because in my opinion, medication has compliance issue. Medication has issues with cost, issues with tachyphylaxis or loss of effects with time. So to me, I would like to get the weight off with a procedure like endoscopic sleeve gastroplasty, and then introduce the medications down the line if I need to for a weight maintenance effect. So overweight, obesity, if they qualify for bariatric surgery, offer bariatric surgery first. If they refuse it, then a combination approach that includes endoscopic sleeve gastroplasty would be the way to go.
Absolutely, and that's also my indication. Imad and Abid, I'll ask you, Imad, when do you offer ESG to your patient?
Again, so when they come to my clinic, usually the first thing I do is I review the history, and if there is no clear contraindications, such as a family history of gastric cancer or anything that would be problematic, then I would just proceed with calculating the BMI. I really do a thorough history and kind of understanding the social aspects of the patients, because really sometimes compliance is a bigger issue. And as one of my patients, she was classic, she was ideal, but I had a concern that she was drinking too much of soft drinks, which could be not prevented. And she failed endoscopic sleeve. However, according to the most recent study that was published comparing endoscopic sleeve gastroplasty and laparoscopic sleeve, they were actually kind of shifting towards, if the patient is of obesity type 1, overweight, then you would maybe, the efficacy of both procedures are actually the same. However, endoscopic sleeve is considered much safer and much more convenient for the patient. Then I would just shift them to that module or type of therapy. But if they were exceeding 35, then I would just, especially if they had like comorbidities such as diabetes, hypertension, I would offer them surgery first, as Dr. Prof. Abudaya mentioned, that it's the golden standard therapy. And that's the way I go, unless if they refuse to go for surgery, then I would just entertain the idea of endoscopic sleeve.
Abid, will you do the same, or you have different approach?
I think I will do the same, and maybe I can add some of important issues. Sometimes there is a contraindication to do surgery. So either from other cardiac risk, or maybe they have high-risk patients. So it's one of the indications. Some very important thing, sometimes the patient is requesting. Okay, whatever they're afraid from the complication of surgery, they're afraid from a major leak or fistula. So it could be sometimes is one of the options. So we have our clinical clear indications, and then we have to take considerations of the patient's preference. And then contraindication usually is a contraindication, so we have to use non-invasive procedures. I will do the same in addition to those points.
Thank you. Eduardo, a question for you from Dr. Abdullah Musa, a question raised, but I'll put it for you. Would it be better to combine endoscopic gastroplasty and coagulation, argopene? You are muted, so maybe we can open your. Yes.
Okay. I never combine this procedure. I don't have experience with combine. When I perform the sleeve gastroplasty, it's alone. I have experience with DMR, do the non-mucosal resurfacing, in Brazil during the protocol, and the result isn't good for weight loss and not interfere for the diabetes in the patient. I agree. I agree in the future possibility to combine the different techniques help for the patient, but I don't have experience in this specific topic.
Barham, quick answer. If you combine, would you have a different result?
So I would say we don't know the answer yet. To me, I'm a little bit torn between two issues of potentially enhanced durability versus simplicity of the procedure. The elegance about endoscopic sleeve gastroplasty is its simplicity, outpatient nature with very low risk of adverse events. And so sometimes you want to just keep it as it is with suturing alone without adding argon plasma. That being said, we have done on trial basis attempting to use APC, and this was introduced by colleagues in Australia, Dr. Sarametto, who started thinking about APC plus endoscopic sleeve gastroplasty. And now we're also trying to do this auscultating circle technique where we do EMR at the location where the U-shaped sutures come together to see if that's going to affect or show us better durability. The answer is we don't know at this point, and the answer is the procedure as it stands is pretty good and effective. And my inclination is not to introduce anything that would make it more complicated or risky, because that's the strength of this procedure: is safety, outpatient, good results.
Quick question for you, Barham. Would you combine ESG and duodenal resurfacing?
I would, and that's going to be a big part of the future, right? Is we know that a procedure like gastric bypass is effective because of weight loss dependent and weight loss independent effects. And now it's not going to be any different for this combination approach. So for this endoscopic sleeve gastroplasty, it will give you the gastric restriction. It will give you the majority of the weight loss dependent effects and improvement in comorbidity. Now you add a procedure like duodenal resurfacing, where it is implicated in changing the signaling, whether it's neurologic or hormonal of the small intestines, and have weight loss independent effects. So the future is going to include the combination. And the added advantage here is you could both do these procedures in one endoscopic setting. That means you could start with DMR and then do your sleeve in the same session. And I think we will see that combination hopefully in the near future.
Excellent. Now we'll have from the attendees, Prof. Adnan Mufti, you have a question? You are raising your hand. I will give you this the mic. Yes, Prof. Adnan. Are you getting the Prof. Adnan? I think. I think okay. Abdurrahman Salim.
كلام فاضي.
I don't think we'll go to Abdurrahman Salim. Abdurrahman.
Prof, can I have a question before you start?
Yes, go ahead, Abid.
So, Prof. Eduardo, for the sleeve stenosis, regular balloon, CRE balloon seem to be is not that effective. So using the chalasia balloon, do you have any specific sizes? You start like a 3, 35, you reach 40, or you have only one size, or you up size with interval?
Yeah, I use the 30 millimeters balloon, esophageal chalasia balloon. And when I have the improve for the center for the patient, if necessary, I use the second session and I use a 35. I never use more than 35. But in general, in my opinion, it's much easy to perform the structurotomy by tunnel line, and you solve the problem immediately. When you use the balloon dilation, you don't have control about the rupture for the fibrosis or the wall. Sometimes you have the perforation. When you perform the structurotomy, you identify the tissue. It's very easy to perform because you section 4 to 5 centimeters. It's very small in the body and antrum transition. In my opinion, it's much better to use this technique than dilation. It's more easy and the very good result for the patient.
Thank you so much. Thank you, Eduardo. I will have to conclude the session at this point. Really, thank you all. Thank you, Barham. Thank you, Eduardo. Thanks, Abed. Thanks, Imad. You really contributed a lot to this, and looking forward to see you in physical appearance, hopefully soon after this COVID issue. We will be moving forward to the next session, which is with the update from Prof. Muhammad Al-Na'mi, who will talk to us about the Saudi Fellowship Program and update on where do we stand with Saudi Fellowship Program. Go ahead, Muhammad.
Thank you very much, Dr. Ayed, and congratulations for the good work achieved, and thanks for all speakers, panelists, who really enriched this meeting further. If I may share the screen, if you don't mind.
Yes.
Can you see the screen now?
Yes, now we see it.
Okay. All right. So it is about the Metabolic and Bariatric Surgery Fellowship Program that we would like to invent under the umbrella of the SASMBS, as well as the Saudi Commission for Health Specialties. Just to give you a background and rationale about this program, a very enthusiastic leader in the academic affairs of the Saudi Commission for Health Specialties endorsed to us to supervise a program, a fellowship program in bariatric and metabolic surgery. We had worked on that since then, and as a matter of fact, there are similar national and international programs that are existing in the locally and worldwide. The local program is a fellowship program in minimally invasive surgery at King Saud University, and I'm part of the trainers in that program that was established since about 4 or 5 years ago. The other international programs, we have the AMBS program, the 2 years fellowship program. We took it as a role model, and we worked on that accordingly. The 2030 vision of our country has emphasized obesity and chronic illnesses as a priority towards the health and well-being of the Saudi population. So that's stimulated the work of having more efforts, including training good bariatric surgeons to deal with obese individuals, or to deal with patients living with obesity. The bariatric and metabolic surgery represent the most effective and durable therapy for morbidly obese individuals. And the public and private health sectors have performed thousands of various bariatric surgery procedures, making valuable contribution to the surgical management of obesity in our country. But more resources are required to respond to the current demands. So we studied the prevalence of obesity in the Kingdom of Saudi Arabia, and we found that more than 40% of the Saudi women are obese, and more than 30 of the Saudi men are obese as adults. In children, it's about 10 to 20% of the population. And the average in adult is about 30 to 33%. And we have calculated that out of this 33%, about 20% requiring surgery. So if we estimate the patient requiring bariatric surgery of the 20% of the obese individual of the total population, then 5 million patients will require bariatric surgery in our country. If we consider that we need 10 active metabolic and bariatric surgeons per 100,000 individuals or population, the total number of bariatric surgeons will be at around 500 that are needed to fulfill the needs and to lower the waiting list in the government hospitals, at least, which are reaching now to 2 to 3 years waiting list. So currently, we have less than 100 practicing bariatric surgeons in the Kingdom of Saudi Arabia. So we need at least 400 specialized in bariatric and metabolic surgery to fulfill the needs of our country. So for that reason, we have a vision at the SASMBS to be recognized as a unique training and research program in the field of metabolic and bariatric surgery at a national and international levels. Our mission is to enable the Saudi Society for Metabolic and Bariatric Surgery as a leading training institute and to graduate highly competent surgeons in that field and to encourage and produce high scientific material in this field through strong research, including the use of a national bariatric registry that are starting to kick off recently in the country. And also to be a national reference in training metabolic and bariatric surgeons. To attract also postgraduate students and senior consultants through the academic activities and program like this wonderful program we are living in. The aim of the program is actually to graduate certified general surgeons to be highly specialized in the field of metabolic and bariatric surgery that certify them further as a competent consultants in laparoscopic and bariatric surgery by the Saudi Commission for Health Specialties. So it's an update on this issue as we have submitted our curriculum. We met with the leaders of the academic and training affairs in the Saudi Commission for Health Specialties, which is the really certifying body and accrediting body for all programs in the kingdom, medical and health specialties. However, we thought that the society, our society, SASMBS, will be handling this program. But after the discussion with them, they are really following the Canadian model, which is the commission should prepare the curriculum and centers will apply for that compared to the North American or the United States model, which actually make the society make the program and we will apply to the society. So the consensus after a lengthy discussion in that regard is that the commission will design the curriculum based on their own expertise and give to the SASMBS the curriculum and the program for revision and final approval in about 1 to 2 months' time. Once the curriculum is ready, then any qualified center that can fit the criteria for application can apply directly to the Saudi Commission for Health Specialties. So it is just a matter of changing roles a little bit, but there is a collaboration between the Saudi Commission for Health Specialties, which is mimicking the Royal College of Physicians and Surgeons in the UK or in the in Canada. And also the society, our society, SASMBS, will be also collaborating with them to put the curriculum and the program. So that's up to date, the issue. And I hope in 1 to 2 months, the program will be ready for applicants. And hopefully more centers will fit the criteria and train the people according to what we have mentioned earlier. So thank you very much. If you have any questions or discussions, please.
Thank you, Muhammad. Thank you. I don't know if somebody have a question, you can raise their hand, because it will be, maybe I don't know if we can bring everybody on board. But if those in the, because we cannot bring you all panelists, but Prof. Adnan, I will give you unmute if you can contribute. Yeah.
Yes, Prof. Adnan, he was also the leader of this initiative, and I would like to hear from him as well.
Yes, Prof.
If
Adnan.
you would add on.
إذا ما قد نام نمت يا أبو نزار؟ طيب. Anybody would like to ask question in the audience? You can just raise hand, please. Attendees. أبو يحيى تتوقع إنه it will be in July? You say?
They promised that by the end of this summer, the program will be ready after we review it in the SASMBS and send it back to them. But the actual start of the fellowship application, I doubt that this year will be feasible. So hopefully in next year it will be ready, not this year, because of the refinement of the curriculum. And really the Saudi Commission for Health Specialties are very careful about having the governance of this curriculum and program, the output or the graduates, they have to be up to the level of their expectations. So it needs really lots of work to assure these mandates.
Okay, thank you so much, Muhammad Abu Yahya. And I don't see any questions. I see, let us see, maybe we'll see here some people raising their hand. Well, I have Abdullah Sultan, Ashraf Muhammad. Ashraf Muhammad, go ahead. You want to ask the question? You can click your mic and you are giving the permission to talk. Go ahead, Ashraf.
Assalamu alaikum. I think this program will be very beneficial for, I work here in Saudi Arabia since around 10 years, and really we have a shortage in bariatric surgeon, as mentioned in this lecture. And I hope this program to include also the non-Saudi people, because we know many of the programs, or most of the programs, do not include the non-Saudi people who are working, even who are working in the Saudi Arabia. They not allow them to be included in such programs. I think we have many of our colleagues of non-Saudi are perfect in the laparoscopic surgery. And as mentioned, if we follow the American or Canadian guidelines, now the fellowship is or in Taiwan and or other countries, is such centers that allow for the non-national surgeon to be included, or even the national, and it will be 1 year only in USA and in South Korea and in Taiwan. It is 1 year fellowship. I don't know if it will be 1 year, and if it will also include the non-Saudi doctors in this program.
Ahmad?
Yes, thank you, Dr. Ashraf, for this valid question. The fellowship program that we are proposing is a 2-year program. because the 1 year we found it is not enough for really clinical and skills competence, as well as having much time for research. So the program is rich in clinical exposure, which is 18 months, to make sure that the products and the outcome of this program will be ideal. The other 6 months are divided between research, rotations in research, endoscopy, and radiology. So that's why it's really 2 years. The other reason that we have the experience with fellows who are graduating from King Saud University minimally invasive program, and they can stand after 1 year. So after 2 years, they will be more competent and ready to practice in their corresponding hospitals. Regarding the non-Saudis, it is open for non-Saudis. However, there are fees, there are sponsors. So once these criteria are fulfilled, then any applicant can indulge in the program.
Thank you, Abu Yahya. Thanks, Prof. Muhammad. Abdullah Sultan. You have a question? Go ahead. Your mic is open, but you should be able to talk. Abdullah. Abdullah? Okay, apparently he has a problem with his mic. Let us see if somebody else. No, I don't see any more questions. And I don't see in the chat. Abu Yahya, thank you so much. Inshallah, it will work well. And definitely we need the contribution from all members of the society to have this program, inshallah, successful in the future.
Inshallah.
Thank you. Thank you for, sorry, yesterday we delayed it today. And
we enjoyed the party last night.
Thank you. Thank you. Have a good night. Thank you, everybody. And we conclude our session. And we'll see you, inshallah, the next year in another annual meeting.